7 review. This is extremely important. So now listen, you see, you have to check the chart for diabetes because diabetes is extremely important. Okay, so diabetes type 2, what happened? The most common uh, etiology to develop diabetes type 2 is insulin resistance. There is a resistance between the insulin and the transport. Okay, remember you have the insulin and then we have the GLUT 1 to 4. Okay, so insulin get the glucose and through this transport put the glucose inside the tissue. If you develop resistance right here, then what happened? The insulin, the glucose is not gonna go to the tissue and you develop the diabetes. Okay, so that is extremely important. Diabetes type 1, remember, is an autoimmune disease. And what happens is diagnosed early in life because those patients are born basically without any beta cell. Okay, remember we have the beta, alpha, and delta cell. Beta cell produce insulin, delta glucagon, and alpha glucagon and delta somatostatin. Okay, so in this case, the patient doesn't have any beta cell, the patient doesn't produce any insulin, develop diabetes. Around like the the age is around 10 years old. Okay, diabetes type 2 risk factor, female sorry, obesity. Why? Because obesity is the patient that is eating too much glucose getting inside to the patient. You start using a lot of insulin with the transport until you develop the resistance. Okay, and then the glucose is still in the bloodstream. And also you have to know the 3 P's. Okay, polyuria, polydipsia, polyphagia. Okay, polyuria is what is polyuria? Polyuria is too much urine. Polydipsia is drinking too much water, and polyphagia is eating too much. Okay, so that's the sign and symptom of diabetes. Okay, exercise. Remember, patients with diabetes they need to do exercise, but the exercise has to be aerobic activity. The patient either has to run or walk like 30 minutes at least 3 days a week. That is aerobic activity. It's not lifting weight, okay? Aerobic activity, okay? Now, in this case, remember, you have to know the micro, M, I, and macro, M, A. So microvascular, this one right here, microvascular is related to the eyes. This is the eye retinopathy, nephropathy, and the nerve, okay? Peripheral neuropathy, okay? So retinopathy, nephropathy, and neuropathy, okay? So they affect the eyes, the kidney, and the nerve, okay? Especially. But in this case, if you have a good control of the glucose level, you decrease the risk and the complication from this one, microvascular. In the case of macrovascular is related to a stroke and MI, myocardial infarction. In the case of macrovascular, this one right here, doesn't matter how much good control and how good you follow the treatment and everything with the diabetes, you are still at risk for a stroke and MI, okay? Especially cardiovascular diseases, okay? Hypoglycemia complication. The hypoglycemia, you have to know the contrarregulatory mechanism symptom. The patient is going to have pallor, tremor, diaphoresis, palpitation, anxiety because of the contrarregulatory hormone. What are the contrarregulatory hormones? Growth hormone, growth hormone, and epinephrine and norepinephrine. Okay, so right here, the hyperosmolar stage. Remember, when we talk about hyperosmolar stage, you have to think about diabetes type 2. Hyperosmolar state, non-ketone bodies. See, ketosis uncommon. You don't have ketosis. You don't produce ketone bodies. You don't get energy from free fatty acid. Okay, because when you get the energy from the free fatty acid, you produce the ketones, and that is the one that made the ketosis and the acidosis. Okay, so hyperosmolar state, diabetes type 2, non-ketone bodies. Okay, so this is education for diabetes. Remember, extremely important, the A1C. Okay, A1C. Okay, A1C is, you see, is the glycosylated hemoglobin. So they measure how was your glucose in the last 3 months. Okay, extremely important. Now we have the neuropathy. Neuropathy, remember, problem in the nerve. Okay, and how do you develop the problem in the nerve? Excessive glucose is thought to interfere with minocytol in neurons and reduce minocytol in peripheral nerve, so you don't break down the glucose and that damage the nerve. Okay. Chronic cholecystitis. What is cholecystitis? Inflammation of the gallbladder, chronic inflammation of the gallbladder. Complication: biliary sepsis and porcelain gallbladder. Why is so important that complication? Because porcelain gallbladder lead to malignancy, cancer. Okay. Acute cholecystitis. Remember, in the acute cholecystitis, we have the calculus cholecystitis. That means that you have um, inflammation of the gallbladder, but you don't have gallstone. Okay, you don't have any gallstone. Okay, you see rapid development of gangrene and perforation. So that's why when you develop that condition, you have to send the patient to surgery to avoid complication. Because if you have gangrene and perforation, you expose the content of the gallbladder to the abdominal cavity, and the patient could develop peritonitis. Cholelithiasis. So cholelithiasis is gallstone. So gallstones is common in Native American more than American Caucasian, more common in women. But also remember the F, 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 F. Female, fat, in their 40 and fertile. That's the classic presentation for cholelithiasis. Okay. Acute pancreatitis. Risk factor for acute pancreatitis. Listen, I always I try to give you the most important one. You have to memorize all of them. But if you wanna, I don't know, you know, to at least get the most important one, alcohol, because that's the most common one. Hypertriglyceridemia, biliary tract disease. Okay, that's okay. But acute pancreatitis, alcohol. Acute pancreatitis, alcoholism. Okay, that's the most common cause of pancreatitis in United States and worldwide. Okay, chronic pancreatitis is recurrent episode of acute pancreatitis, and in this case, you have to be very careful with malabsorption. Okay, especially of liposoluble vitamin. Okay, A, D, E, and K. Acute pancreatitis diagnosis, lipase. So you could see lipase, abdominal X-ray, but the one that you have to pay attention. So the most important, lipase, the most specific one, and the gold standard, CT scan. See, those are the two most important that you have to pay attention. Okay. Now we have cholesterol gallstone, the formation of the stone. You have the supersaturation, nucleation of crystal, and hypomotility. So that's how you develop the gallstone. Okay. Hiatal hernia. What is a hiatal hernia? So hiatal hernia is that you have, remember, this is the diaphragm, and then this is the esophagus, and after the esophagus, then you have the stomach. In hiatal hernia, this is the diaphragm, and then what happened? One portion of the stomach go to the abdominal cavity. I mean to the thoracic cavity. You see protrusion of the stomach to the thoracic cavity through the diaphragm. Okay, that's hiatal hernia. Clinical manifestation like GERD. Okay, what is the clinical manifestation of GERD? Reflux. Okay, heartburn, chest pain. Okay, that's the manifestation. Esophageal varices. Esophageal varices, remember, this is extremely related with liver disease. Okay, so you have a liver disease, what happens? You increase the portal pressure, the portal pressure. If you increase the portal pressure in the esophagus, okay, in the lower portion of the esophagus, right there, we have like little veins, okay, and due to that extremely high pressure in the portal circulation, you have like engorgement of those veins, okay, engorgement, and then what happens? They are at risk to break and have bleeding. That's why you have high mortality rate, because if you break this one, then you leakage the blood out, and then you have a massive bleeding. Okay. Peptic ulcer disease. This peptic ulcer disease, remember, is activation of the pepsin, okay, and it's a hormone to use for the digestion of protein, and that produce ulcers in the stomach, okay. So that's the problem right here in peptic ulcer disease. Clinical manifestation: epigastric burning pain, okay. And then you have to know that in the peptic ulcer disease we have, let me see, eh, you have the gastric and the duodenal. Okay, the pain in the gastric is when the patient is eating. The pain in the duodenal is like 2 or 3 hours after the meal. Okay, neck. Okay, remember another name for necrotitis enterocolitis is just neck. Okay, so necrotitis enterocolitis extremely related to premature baby. Remember, it's not 34, it's 37. Okay, less than 37. Premature baby. with diarrhea, necrotitis enterocolitis. Okay, it's necrosis of the colon. You see, bowel ischemia, that's necrosis. Ulcerative colitis. What is ulcerative colitis? Is an inflammatory bowel disease. Okay, in the inflammatory bowel disease, we have ulcerative colitis and Crohn's disease. Okay, ulcerative colitis is extremely related to cancer, colon cancer. Okay, and the patient, because in both the colon colitis, in both the colon, is gonna have the presentation is bloody diarrhea. Okay, appendicitis. What is appendicitis? Inflammation of the appendage. The most common is a fecal obstruction right there, and then you have to do a surgery. Okay. Celiac disease is a malabsorption disease. Okay, malabsorption disorder. So what happens is that you have problem with gluten. Okay, you see you have atrophy of the intestinal villi. That right there in the intestinal villi, you have the enzyme to break down the gluten. If you lost that enzyme, gluten is still, hanging around in your body and produce diarrhea, malabsorption. Dumping syndrome. What is dumping syndrome? Basically, you are dumping the food from the mouth to the duodenum. You don't have a stomach. That's why it's common in patients with gastric surgery. So that food go straight to the duodenum, and then that complex material that is right there in the food produce diarrhea in those patients. So what is the treatment? Little portion, little, you know, lot, couple of times in the day, but little portion of food. Okay. Gastritis. Gastritis is, what is gastritis? Inflammation of the stomach and the duodenum. Okay, and it's extremely related with Helicobacter pylori. Okay, Helicobacter pylori. Stomatitis, inflammation of the oral mucosa, could be produced by millions of things, especially the herpes simple virus. Okay, gastroesophageal reflux. What happened in gastroesophageal reflux? Okay, remember, this is the esophagus, and right here we have the joint between the esophagus and the stomach. This is an sphincter, and it's always basically closed. It's a little bit closed. So what happened in the gastroesophageal reflux? That sphincter is wide open, never closed. Then the content that is right here is gonna back up to the esophagus. Okay, and the patient could develop Barrett esophagus. Okay, that is a metaplasia. You replace the tissue from here by the tissue on the stomach. That's Barrett esophagus. Okay, and then what happened is a precursor for malignancy. So gastroesophageal reflux, remember, is when the content of the stomach go back to the esophagus, okay? And that could produce Barrett esophagus. Barrett esophagus is an example of metaplasia. And metaplasia is a precursor for cancer, okay? Colon cancer. Listen, the colon cancer, what do you have to know right here? Presentation. If you have in the right side, black Terry stool. Left side, intermittent abdominal pain. The rectum change the bowel habit, okay? So you have to know the presentation. Growth hormone, remember, if you have too much growth hormone, only two diseases, okay? Giantess in childhood, acromegaly in adulthood, okay? Hypothyroidism, that means that the thyroid gland is hypofunctioning, okay? The disease that you have to know right here, Hashimoto, is an autoimmune disease, okay? Then T3 and T4 is gonna be low, and TSH is gonna be high. Diabetes insipidus. Remember, diabetes insipidus is a problem with the ADH, antidiuretic hormone. Diabetes insipidus, the ADH is not working. You either are not secreting ADH or the ADH is not working. So what's going to happen in those patients? They are going to produce a lot of urine. Okay? You see, it could be central, you don't produce ADH, or nephrogenic, the ADH is not working in the kidneys. Okay? Jaundice. What is jaundice? It's a sign of liver disease. Okay? It's the yellowish of your body, especially in the eyes, but could be in the whole body. Okay? In the skin, everywhere. Okay?
I need to grab my PJs. I need to grab my PJs.
Después,
Pijama.
después te lo doy que estoy trabajando. Okay, sorry, I have a problem. My song is right here, but I'm back. Okay. So I was saying that jaundice is the yellowish coloration of the skin, okay, and it's related with liver disease, okay. So now we have hepatitis. I didn't cover the liver because there is not so much question on the test about the liver, but from the liver you have to know hepatitis B, okay. Risk factor, how do you get the hepatitis? Right here, perinatal healthcare setting. So that's why when you get to the hospital, you need the hepatitis vaccine. Transfusion, dialysis, acupuncture, tattooing. So anything that is related with needle and the blood, you could develop hepatitis. Okay. So incubation period 2 to 3 months. Okay, 2 to 6 months. Sorry. So in the hepatitis B, you have to know the serology. Listen, this is the most important hepatitis, okay? So hepatitis A, let me explain right here. We have hepatitis A, B, C, D, and E. So hepatitis A is A for acute. In hepatitis A, the patient develop like diarrhea. Another name is traveling diarrhea, okay? Hepatitis B is this one. Hepatitis C is another that is extremely important. Why? Because the patient could develop cancer and cirrhosis because it's chronic, and we don't have vaccine for hepatitis C. We have vaccine for hepatitis A and B, but no vaccine for hepatitis C. Hepatitis D, what is important from hepatitis D? That you need the core from hepatitis B. So you need to be infected with hepatitis B in order to get hepatitis D. Okay, and hepatitis E, what is important, extremely important for hepatitis E, that is extremely fatal in pregnant ladies. Okay, so now how do you get the hepatitis? A and E are fecal oral transmission. Okay, then B, you see, by the needles, okay, C by the sex, okay, and then you have the serology right here, okay. So you see HBS antigen. This is antigen and this is the antibody, okay. You have the antigen early activation and chronic infection. If you have the antibody is resolution or immunity because you develop the antibodies against the antigen, okay. The core antigen is appear first in active infection, and the core antibody is the seroconversion. Okay, and E is for infection, infectivity. Okay, so that's the thing that you have to know about hepatitis B serology. So now we have the alcoholic fatty liver. Okay, so it's the patient that develop like accumulation of fat in the liver due to alcoholism. Okay, and we finish right here with the review. Any question, people? Hello, hello.